My name is Oliver Findl. I'm from Vienna, Hanusch Hospital. At the Lunchtime Symposium of Rayner, I'm presenting the study we did, a randomized controlled trial of limbal relaxing incisions. Actually, we should call them peripheral corneal relaxing incisions versus toric IOLs, in this case the Rayner Toric. So one eye received the toric IOL and the other eye got the spherical model of Rayner, non-toric, but the LRIs with a 600 micron knife and the Donnenfeld nomogram for correcting astigmatism. And we had patients from 1 diopter up to 2.5 diopters of astigmatism for inclusion criteria. And essentially the quintessence of the study is that for higher degrees of astigmatism of 1.75, 2 diopters or more, the toric IOLs outperform the limbal relaxing incision for correction of astigmatism. And in those where the astigmatism was 1 to 1.75 diopters, they were pretty much head-to-head. We do see that with LRIs we have more variability. In some patients they work well, in others they don't. This probably has something to do with the viscoelastic properties of the cornea being different from patient to patient. With a toric IOL, the good thing is your prediction is a lot better. You have more precision, and that is also why we have changed our paradigm, we have changed our sort of guidelines internally for our hospital. So we offer all patients from 2 diopters onwards with keratometric astigmatism toric lenses from now on. We used to have 2.5 as our cutoff. Well, luckily we don't have to manage the rotation of toric IOLs very often. Actually, it's something which, at least with the Rayner Toric, and we've done a trial on stability, on rotational stability of the Rayner. And actually, if you want, in 2 other trials where we've compared it to LRIs, and also for the multifocal LRI and toric multifocal. And we've always looked at rotational stability. So we took photographs half an hour after surgery with a dedicated retroillumination camera where we can very well define the axis of the toric IOL. And then 1 week and 3 months after surgery, we took photographs again. And we saw that the rotational stability of the Rayner Toric is very high. Rotation of the IOL after surgery is a very rare incident. What you may have is you may have misplaced the lens. You may have not put it in the ideal situation, in the aimed meridian, because of imperfections when marking the eye before surgery, or during surgery. You were aiming for 80 degrees, but you were just 5 or 10 degrees off, because that's not much, and that may happen in some patients. Ideally, it shouldn't happen, or should be very little, but that's things that do happen. In these cases, it's not the rotation of the lens, but it's actually misplacement during surgery, or not perfect placement, or misalignment if you want. So I think if you have these situations, it's probably usually good to wait about a week, because the capsule will start to close. That means the anterior and posterior capsule will start to seal, but they're not completely sealed yet. And then is a good time to rotate the lens. I think if you do it too early, if it really is a lens which is rotating because you have a very big capsular bag, like in highly myopic eyes, for example, then you should wait a little and not rotate too early. Obviously, you also don't want to wait too long, because then you will have fibrosis of the capsule bag, and that may make the surgical maneuver a lot more difficult and may also impose risks on the patient. The rotation, if you do need to do a rotation, and we have the experience that we need to rotate a lens, maybe 1 out of 200, so in 0.5%. And if you need to do that, it's a very simple maneuver. I actually don't put viscoelastic into the eye if possible, so no viscoelastic substance. But I just go in through the paracentesis with a cannula, with a 30 or 27 gauge cannula, and while keeping the eye inflated with BSS, I try to manipulate the lens with that. If that works, that's the easiest way, because if you're introducing viscoelastic again, then you have to be sure that you're completely removing the viscoelastic, because that, if you leave viscoelastic, will obviously allow the lens to maybe rotate more freely. But again, rotation, at least of the Rayner Toric, is something we see very rarely. So luckily, we don't need to do that procedure too often.